All right, perfect. All right, welcome all to one of our study sessions here. And first of all, let me thank Eseosa for organizing this. It's always a highlight when we can have one of these. And um, I'll be leading. I'm Mattia, one of the PGY threes working at the Medical University of South Carolina as a neurology resident, and I'll be leading this conversation and this discussion on neuropathies. It will be a general overview. It's such a complicated topic. I'm sure Isilda would agree that we see really the full spectrum of neuropathies in neurology as residents, and you really see it everywhere. And like the setting will really define what kind of pathologies we're looking into. And I'll let the students and the other participants introduce themselves. And if people trickle in, they should feel free to introduce themselves. But please, guys, if you want to introduce yourselves.
I can introduce myself. Hello, everyone. My name is Frida. So I'm currently a second-year medical student in Florida. So I haven't taken neurology yet, but I'm just here because I'm really interested in going into neuro and I wanted to just learn more. And that's why I hopped on to this study session.
Excellent. Welcome.
Thank you.
I think we have at least another person. I know it says I will not be able to speak because she's otherwise engaged. But I think we have Sarah maybe on the call.
I'm Sarah. I'm a neurology resident at Mansoura International Hospital in Egypt.
You said you're a resident. Sorry, I couldn't really hear you.
Yeah. I'm a neurology resident. Yeah.
Oh, excellent. So I'll be asking you for some contributions during the presentation for sure. And guys, if you have any questions, please feel free to interrupt at any point. It's far from a formal setting, of course. Yeah, of course. So let's see if I can share my screen. I have a presentation. I believe that I would need Esilza to give me the reins of the presentation. And while we're waiting for that, I guess we can start with the general question. We can start with the med student, but again, it's absolutely fine if you don't know. But the term neuropathy, I always feel like in neurology we use all these terms that end with a pathy, and they can become a bit confusing, especially because you hear this term a lot, and you kind of have sometimes we may have a false illusion to really understand them, and then you may get confused. So, if you were to tell me, what would be your idea of what a neuropathy is?
I would think it's like a damage to a nerve. That's what it would, that's how I would describe it. And then that would affect like whatever the nerve innervates, that would affect would determine the consequence of it.
Absolutely. That's correct. And really the way to organize it, you're absolutely right. It's a disease of the nerve, and that's really the best way to think about it. And then a way to further organize, is there something about the nerve that you may have studied, for instance, in your first year, maybe, or in college even? What about the nerve? What are the ways in which nerves are different and that can sort of help us further elucidate which nerves are being affected?
Like I could think of like maybe the myelinated nerves, if you're talking about like the different types of nerves, or the sensory nerves and the motor nerves. So I can think of like those different types of nerves, but I'm not sure if I'm answering your question correctly.
You are. So now, taking a step back, whenever we're dealing with the pathology in neurology, right? Let's say I'm in clinic and one of my patients is a 65-year-old person, with a history of diabetes and hypertension, hyperlipidemia, who presents with, slowly ascending numbness and tingling over the past 2-3 years, that would lead me to a very different answer and very different diagnostic consideration than I would if I have someone in DED who presents with 2 days of rapidly ascending weakness and numbness, right? So you're absolutely right. In doing what I'm doing right now, I'm thinking about the time course and then the modality, which is what I was getting at, and you covered some of it, is really trying to understand whether there is sensory involvement, motor involvement, sensory and motor involvement, and autonomic involvement, right? So that's one way to think about nerves. And then you're also right, like some nerves are myelinated, some nerves are unmyelinated, right? And then those that are myelinated are mostly the large fiber nerves, right? And they carry more advanced modalities like vibration science and proprioception. Whereas the small fiber nerves that are not unmyelinated, do not have myelin, they carry pain and temperature, right? So already here, we're looking at a very important distinction where we're looking at whether there is motor involvement or not, whether there is autonomic involvement or not. Most of neuropathies will have a sensory involvement, and then really understanding which modalities are being hit. And we'll go into how to do that in a second. And then the other thing that's important is axonal versus demyelinating, and we'll talk about how those processes are distinct. Taking a step backward, though, it's also about the number of nerves that are being affected, right? So you may have a mononeuropathy, which is where we have only one nerve. And is there a setting you can think of that there are lots of mononeuropathies, but is there a setting where you guys may encounter this a lot? So I can think of one specific mononeuropathy is very common, right? It's carpal tunnel syndrome, and someone will present with numbness and tingling that's affecting the more lateral aspect of the hand. Usually, it's sparing the the thenar space right here, and it's just affecting the wrist, and then it's affecting the 3 digits and 1/2 of the ring finger. That's a very common neuropathy. And in general, mononeuropathies are either caused by hyperacute trauma. That's one of the few times, and we'll talk about time course later, but that's one of the few times we see a neuropathy that can develop within seconds. And that's really a rarity in neuropathies. So trauma can definitely cause a mononeuropathy, and then chronic wear and tear, right? And there are all these different mononeuropathies that you may have, you will certainly study in med school, and carpal tunnel syndrome is one, and they have Saturday night palsy, where you have compression of the radial nerve, and we'll talk about all of those. But in general, those are more can be either acute compressions, where Saturday night palsy, famously, someone will have the compression at the axilla of the radial nerve because of falling asleep in an awkward position, and they will resolve quickly. And then otherwise, something that's more chronic wear and tear of carpal tunnel syndrome in people who spend a lot of their day at the desk or typing up, or folks who have acromegaly but have had a slow increase in the connective tissue compressing the nerve. So in general, mononeuropathy, think of compression. Polyneuropathy is when we have multiple nerves that are affected in a sort of symmetric, at least organic fashion. And the last one, which is sort of a zebra, is mononeuropathy multiplex, where it's almost like the immune system, because it's mostly an autoimmune phenomenon, not always, but it's almost like these nerves are picked and chosen. So it's sort of like a bunch of different random mononeuropathies. This is more of a rarity. It's a rarity for med students, for sure. It's something that we need to think about in neurology, but it's still a relatively rare presentation. Now, talking about the last piece of the puzzle here, so polyneuropathy, we talked about modality, we talked about fiber, and the last one is axonal versus demyelinating. Now, this definitely overlaps with the fiber type being affected, but I think it's important to also think about how these present, and it's pretty remarkable how differently these two present. Now, can anyone tell me what would be the example, the most famous example of a demyelinating polyneuropathy?
Maybe Guillain-Barré syndrome.
Yeah, so that's right. And it's a specific kind of Guillain-Barré, though. And to be fair, it's almost the vast predominance of Guillain-Barré. You're right. So it's something that has the time course of Guillain-Barré mixed with the type of neuropathy in the name. And it's an acronym. It's an acronym that you've certainly come across.
I'm so sorry, I did not hear the question properly, but I guess you're asking about the time course in case it's acute or chronic, like AIDB or CIDB.
Yeah, exactly. You hit the nail on the head. And can everyone hear me, by the way?
Yes.
Okay, perfect. Yeah, you're right. So it's called acute inflammatory demyelinating polyneuropathy. And that's sort of a synonym as Guillain-Barré. Think of Guillain-Barré as sort of the broader presentation of acute inflammatory neuropathies. But most, if not all, especially in the States, especially in Europe and the States, will be acute inflammatory demyelinating polyneuropathies. So, and to be fair, actually the P stands for polyradiculoneuropathy, because Guillain-Barré or AIDP will affect both the root and the nerve. And usually these are patients who present within a couple of days. They go from having some numbness of the feet, most commonly, and then they have a pattern of weakness that seems to be going up, right? It's important to know that these patients may decompensate pretty quickly. They may have respiratory problems, they may have facial weakness, they may have something called facial diplegia, and they can become even paralyzed within a couple of days. Now, this is really different than what we think of axonal neuropathies, right? So when we think about demyelinating neuropathies, we're mostly looking at inflammatory phenomena. So we're talking about a disorder that presents with inflammation and will affect the myelin everywhere in the body. So while it is true that usually it starts in the lower extremities and then it goes up, it's a different kind of, it's a different ascending pattern than you would get with an axonal process. So I just want to make sure this is a really important point to figure out. I think I may have a slide on this. The phenomenon of length dependence and length relatedness. So an important thing that we always discuss in neurology is whether a neuropathy is length dependent or it's not. And length dependent processes, in my mind, are the same thing as axonal processes. So in a length dependent process, the longest nerves, the ones that go from your back, from your spine, and go all the way to your feet, those are affected first. And then usually over the course of months to years, shorter and shorter and shorter and shorter nerves are affected, which is why with an axonal neuropathy, you will not really have any bladder problem. And you should not have anything that goes out of order. You shouldn't have the feet being numb and then hands being numb. And that's something that you guys may have heard of as the gloving stocking phenomenon. I see you nodding there. Can you tell us what the gloving stocking phenomenon would be, or neuropathy would be?
I remember learning about this in endocrine, about how I think it was a diabetic neuropathy where it just starts slowly, but then it goes up. So it's like the glove stocking.
Exactly. And what it means is that, so it's not how it will present always, right? By the way, it's just that at a certain stage, by the time the numbness has gotten all the way to the mid thigh mostly, it will start affecting the fingers as well. And I think of it almost, if you were to look at the length of your nerves, if you were to sort of measure your hand against your leg, you would see that by the time it gets to that height, it'll start affecting the neuropathy, will start affecting the fingers as well. But it shouldn't go out of order. And now, the reason why it's axonal processes that have this length-dependent phenomenon, the reason is that axonal processes will affect the axon, so will affect the cell body, which is really where all the nutrients will be made. Everything gets synthesized there, and then it has to travel from the cell body all the way down to the to whichever part of the nerve and the neuron is being needs to have nourishment, right? So logically, even if you have some energy failure at the axon, some food will be made, some nutrition will be made, and the parts of the axon that are closest will be provided with nourishment and nutrition, whereas the ones further will not. And the same goes for longer axons. Will have a harder time getting all the glucose, all the ATP, all the way down to the end of the axon. Does that make sense? So that's it for axonal neuropathies. Now, the confusing thing, at least for me at some point, is that we also say that AIDP is ascending. And that's an ascending weakness, but that doesn't mean that it follows the same order, right? So patients may present originally with some numbness or tingling of the fingers, and then usually they start having the weakness, which is more at the level of the girdles. So it may be the hip girdle first, because it's a polyradicular neuropathy, so it affects those muscles too. And then it leads to weakness that's more prevalent in the lower extremities, but that's more so because there is more myelin for longer neurons, and also there is more surface area, to be quite honest, in the lower extremities. So those are statistically more likely to be involved and affected. And again, the longer the neuron is, the more myelin it requires. So that's also why we have this ascending pattern, which is more of a length relatedness than length dependence. Does that make sense? And do you guys have any questions about this? If not, we can keep going with the one more comment that I wanted to make about these. One more comment about the demyelinating processes. Mostly, again, we encounter this in acute inflammatory demyelinating polyradicular neuropathy, the one additional point that I'll make is that there is also, as Sarah was saying, there is also something called CIDP, which is the chronic variant of AIDP, but we'll go into more details in a second. So here is just the summary of what I was saying before. Axonal processes, I think of energy failure, and the long and the short of it is that, and I think Freda is that how you pronounce your name? Or
Yeah, it's Frida.
Frida was making this point, right, about diabetic neuropathy. That's definitely one that's axonal. Can you think of any, and again, everyone who wants to chime in, can you guys think of any other axonal neuropathies that you guys can think of? There's, I think a hint I can give you is if we were to go back to the story that I was telling before, you know, let's say a 65-year-old person with hypertension, diabetes, presented in the clinic with this years-long pattern of numbness and tingling that slowly ascended without any weakness, without urinary incontinence and no other red flags. What would be the things that you would be curious about, or the things that you would like to check maybe on labs? And Sarah saying diabetic neuropathy, completely agree, absolutely. We'll check an A1C. Is there anything else we should be thinking about, I guess? There is a vitamin that we usually check routinely in these patients. So the B12 is another thing we check, which can cause a neuropathy. I'll get into more detail about B12 because it's not as straightforward as we'd like it to be, and we'll talk about that in a second. And then the other thing that we always check is an SPEP and a UPEP for monoclonal gammopathies, but we'll talk a bit more about that. But in general, sort of taking a step backward, and those three, by the way, I didn't pick them at random. Those are the AAN, the labs to check in a patient with neuropathy by the AAN practice guidelines, and there's a reason why they pick those. But in and of itself, axonal neuropathies can be due to a wide variety of causes, and usually think of them as toxic metabolic. And breaking the toxic metabolic a bit more, I think of diabetes. I think about vitamin deficiencies from, any vitamin of the B spectrum can cause a neuropathy. B12 famously causes something called a myeloneuropathy, which is a combination of a spine disease, which is a myelopathy, and nerve disease, which is a neuropathy. By the same reasoning, B1 thiamine can cause a neuropathy. Frida, I'm sure you heard this in med school. There's something called dry beriberi that presents as a usually painful neuropathy, but it can be painless too. Niacin can present that way. Vitamin E can present with the neuropathy, and the list goes on and on. Copper can present with the neuropathy as well, though it's more myeloneuropathy. And then for toxins, a couple of things that are really important to remember. Alcohol, common cause of some degree of neuropathy that I've seen be severe at times. Ethanol, and then it's really important whenever thinking about toxic causes to think about common things, which are meds. Can you guys think of any medication that famously presents with a pretty severe neuropathy? Actually, I think every medication could, but there's a couple that I think are important to keep in mind. I can look at the chat. Well, just to avoid doing a can you read my mind exercise, because it may be it may be a direct association for me, but it's not the only one for sure. So one that I think about always is chemotherapy. Taxane chemotherapies, commonly, paclitaxel and medications like docetaxel as well can present with a neuropathy. There's also, go ahead.
I think anti-tuberculous drugs maybe can cause neuropathy. That's what come on my mind.
Yeah, I think ethambutol, right? Am I mistaken on this?
Yeah, maybe ethambutol or I think isoniazid maybe.
Yeah, yeah, yeah. No, absolutely.
Hmm.
Yeah, and the list honestly goes on and on. I just decided to pick on chemotherapies, but you're absolutely right. If we're thinking about antivirals, then we also have to think about didanosine, for instance, commonly. But in and of itself, a good rule, I think, especially for Frida, who's about to go into the wards, I believe, or next year, I suppose. A good rule of thumb is that you always need a good MedRec, right? And especially now that there are so many medications and so many new classes, right? It's important to look up the medication list if you have something that doesn't make sense or a new presentation, and you may find, common and uncommon side effects. But in general, chemotherapeutic drugs, radiation, antivirals, antibiotics, those are really powerful medications that can present with damage to the cells, which means damage to the axon, which means an axonal neuropathy. Demyelinating, we've already touched upon. I think of demyelinating as inflammatory. And then it's important to keep something in the back of our minds, and this is honestly more so for residents than for students, I feel. But there are some forms of hereditary neuropathies that can present with either demyelinating pattern of neuropathy, which is mostly Charcot-Marie-Tooth, and the other one is hereditary neuropathy with pressure pulses. I'll say one thing about this disease is that these are in HNPP, hereditary neuropathy with liability for pressure pulses. They will present with a tendency to develop mononeuropathies in response to pressure, to compression. So we talked about compression and mononeuropathies. Well, these folks, unfortunately, have a really easy time developing neuropathies due to compression. So they have this tendency. And I guess the one fun fact about CMT and HNPP is that they are both due to the same mutation, but a different kind of mutation. So there's a protein called PMP22, which is a very important protein for important gene for the structure of myelin. It's one of the proteins of myelin. And if there is a duplication, the presentation will be a hereditary neuropathy in the CMT family. Otherwise, if they have a deletion, it'll be HNPP. And then finally, there are some other axonal neuropathies in the hereditary group. And I guess for Frida, I think an important thing to keep in mind, or one thing, the only thing probably that you'll ever hear in med school about CMT, Charcot-Marie-Tooth, is high arches. I think high foot arches, probably that's one where you may get tested. But otherwise, it's more of a obscure entity, I suppose. All right. So I adapted this schema from a really good book that I recommend to all students, I think especially for residents though. And it's a book by Price, that was released last year, and it asks how to deal with the distal symmetric polyneuropathy. So again, distal symmetric polyneuropathy is the more formal way to phrase or to think about the glove and stocking phenomenon. And I really like the term because it really gives us a good descriptor, I feel. And the first thing that you need to ask is whether there are any red flags. And again, we touched upon some of the red flags, and I think the time course is the most important thing, right? So we talked about the two different scenarios where someone presents in the ED with a weakness with a sensory loss and weakness that has developed over days. What we're thinking is really different than what we would be thinking with someone that comes to our clinic and has had numbness for months and years. That's an important red flag. And then, so rapid progression here. Motor involvement is another red flag. You shouldn't really have significant motor involvement with a regular distal symmetric polyneuropathy unless the sensory loss has gotten to a very advanced level. And then any marked severity, loss of functional abilities. And a couple of things that we'll add is looking for things that don't quite fit with the neuropathy. So if someone presents with sensory loss, we may definitely think about neuropathy, but what are some other things we should be looking for? Would we expect someone with a neuropathy to have, for instance, loss of bowel control? Would we expect them to, I'll get to the exam in a second, but would we expect them to have severe falls or have spasticity, for instance? We usually don't. So usually, we expect a neuropathy to have a lower motor neuron pattern of weakness, which means reflexes would be decreased. They wouldn't have spasticity, and the bladder should be spared, really. It would be really hard for bladder and bowel involvement to be there, given how short those fibers are. And if bladder and bowel involvement would be present, I would mostly think about, well, something like a cauda equina or a conus medullaris kind of phenomenon, where the cord or the end roots of the cords are being affected. If there is spasticity, I would have to think that the spinal cord at some other level is being involved. And if there are early falls, well, while it could definitely be more of an acute presentation, it's definitely a red flag, and then it kind of opens up my differential thinking. Now, if those are all negative, then we do the workup that we talked about, which is an A1C, a B12 level, an SPEP with immunofixation. And let's talk for a second about why these have been picked. We talked about A1C. Diabetic neuropathy is very common. B12 deficiency, I haven't seen too much of it. And when it's present, it's severe, but it's still something that's easily reversible, right? So that's where we check it. And the last thing is an SPEP with immunofixation. What we're looking for there is a paraprotein, is a monoclonal spike. And these are not very common. And what we're looking for there is paraprotein-associated neuropathies that can be due to anything from MGUS, multiple myeloma, amyloidosis, any kind of Waldenstrom, microglobulinemia, any kind of plasma cell malignancy or dyscrasia. It's not that these are common either, but it's important to recognize them. So what we're looking for in these labs is anything that is either common or easily reversible or would portend a very poor prognosis. And so we have these here. Now, any red flag should then be assessed with the EMG nerve connection study. I think a common question to ask is whether we need EMGs on every single patient with neuropathy, and we don't. Most of these patients will have a pretty straightforward cause without any red flags, which doesn't require a nerve connection study. The reason for doing a nerve connection study, though, is that that would allow us to understand whether the etiology is demyelinating neuropathy or not. So that's a very important modifier, and you'll see that our workup becomes way more expanded and expensive if we have any red flags, any reason to believe that something else is going on. And I want to go back to one of the prior slides that I had, which is really looking at neuropathies by time course. Now, we talked about the hyperacute neuropathy, which is mostly due to trauma. For acute neuropathies, the list is also small. And the good news is that it's almost always AIDP, I will say. It's almost always Guillain-Barré, or some of its variants, either an inflammatory variant or more of an axonal variant. And then there are some other exceptions. Porphyria famously causes an acute neuropathies. It's pretty rare, I'll say this. Toxins are also important. Arsenic can present acutely, also pretty rare. And then the last thing that's important to recognize is organophosphates. Organophosphates can present with a delayed but acute neuropathy. And I think the last one that I can think of is more of a diphtheritic neuropathy that can also present acutely. But by and large, I think if something is hyperacute, I think of trauma. If something is acute, I mostly think about Guillain-Barré. And then the tricky part becomes when we're out of that acute window, and that's most of what we deal with, along with GBS as well and isolated neuropathies. But it's important to know that whenever we have a patient in the clinic, it's mostly going to be in this group here. And there, we're really using our investigation into red flags to know how deep we should go. And again, just as a review, axonal neuropathies are mostly toxic metabolic, B12, diabetic, uremia, medications, we covered a few of those. Infections, HIV, HCV can present that way with neuropathies. And finally, paraneoplastic and paraproteinemias, also very important. And then we go into the more severe non-length dependent forms of neuropathy, which are our demyelinating group. And in addition to CIDP, which we mentioned, it's really important to think about another group, which is rheumatological neuropathies. Now, rheumatological diseases can present in any which way. They can affect the nervous system in any which way, but they commonly cause polyneuropathies. And this is really your vasculitis, your Sjögren, lupus, and so forth. They can present either with a pretty symmetric polyneuropathy or even more commonly with a mononeuropathy multiplex, where multiple nerves are picked at random, as we were saying earlier. Then sarcoidosis, amyloidosis are also demyelinating. And then we talked about our hereditary causes already. Any questions so far? So just as a quick recap, what are red flags? Well, they're young patient, acute or subacute time course, which would really make you think, at least in the back of your mind, about a GBS type of presentation, motor being involved more than sensory, marked severity, and then we talked about the practice parameter for DSP. All right, so we can switch gears briefly. We have a question from the chat. Yeah, it was nice having you, and I think we'll have the recording on the YouTube. So when we talk about small fiber neuropathy, this pops up from time to time, I feel, and it's usually in patients who have an extensive degree of allodynia and hyperalgesia. And does anyone know the difference between these two? So I think of allodynia as pain whenever we're confronted with a non-painful stimulus. So for instance, if I were to touch my arm and I were to feel pain, that would be allodynia. Hyperalgesia is when a stimulus which should be either very mildly painful, like pinprick, or even painful, but is encountered with a degree of pain that's out of proportion, then that would be hyperalgesia. On exam, folks with small fiber neuropathy will have a diminished pain and temperature sense. They may have it, but it could also be that their threshold is so high that you will not even be able to test this. And these can be pretty frustrating consults for the patients and us, because it's so hard to find objective data on our exam. The EMG nerve conduction study is useless. Not most, but some of these will be small fiber neuropathy and a large fiber neuropathy. I will say most patients with diabetes have some element of pain, have some element of painful tingling, have some element of dysesthesia, right? And that goes into the positive symptoms. But some of these folks may have just a small fiber neuropathy. So I think of metabolic diabetes, toxic ethanol, again, HIV, HCV, and then a lot of rheumatologic disorders present this way because of the position of antibodies in the small fibers. And a way this could be tested is to do a dermal biopsy. You can send patients for a dermal biopsy to get objective data that there is a small fiber neuropathy. And in some cases, this can also be important, because you may be able to get the biopsy, you may be able to stain it and, for instance, prove that it was a amyloidosis causing small fiber neuropathy, just to give you one example. And again, this is different than a nerve biopsy. It's a dermal biopsy of the skin. It's skin biopsy. Treatments can be helpful. And I think in terms of treatment, most of the time, whenever we have a distal symmetric polyneuropathy that's axonal in nature, our patients will ask us, what can they do? And there is really no treatment for them. But there are treatments available, on the other hand, for the positive, painful symptoms, both of any neuropathy, but especially for small fiber neuropathies. So we can treat the pain, and amitriptyline, duloxetine, gabapentin, pregabalin are all options. There are also topical solutions that can be applied, such as solutions with capsaicin, and those can alleviate some of the pain these patients are experiencing. So just a note on painful polyneuropathies. The list is huge. The ones I think about mostly are thiamine, diabetes, HIV, Sjogren. And then we can just chat about demyelinating neuropathies. And unfortunately, I have the question that I wanted to ask on the slides, so it's giving it away. But the important branching point in demyelinating neuropathies is really understanding whether the time course is within 8 weeks or longer than 8 weeks. And if you're thinking about longer than 8 weeks, you're really thinking about a chronic inflammatory demyelinating polyradicular neuropathy, which is CIDP. Otherwise, you're thinking about AIDP. And that's mostly the most important division. Now, does anyone know how we treat AIDP? So it's an inflammatory presentation. What would be a good way to treat this, do you think?
Could we give like NSAIDs to help treat the inflammation?
Okay. NSAIDs would treat some element of the inflammation. It wouldn't actually help those. Yeah, so Sarah was saying IVIG and plasmapheresis, and that's absolutely right. So we usually choose one or the other, especially because we don't want to give IVIG and then do a plasmapheresis, and I'll say that in a second why. But the important thing that Sarah was pointing out, or the thing that she didn't say, which was correct not saying, is that we don't treat the AIDP with steroids. Steroids actually make AIDP worse. We can give them for CIDP, but not in AIDP. And then IVIG is one option. Plasmapheresis is another option. They're pretty much equivalent. Usually, not usually, but I guess sometimes we go for IVIG, mostly because it's the faster option. You can just order it and have it given to the patient the same day within a couple of hours. Plasmapheresis is plasma exchange. So really what we're doing is we're taking the blood from the patient, we're removing the antibodies, and we're putting the blood back in, or the serum back in. It's ultrafiltrated. So it requires a central line, it requires our colleagues from nephrology to be there, or at least to be activated, and that can be done expeditiously, but it still may have some delays. Now, and this will not be a talk on AIDP in and of itself, because it will take its own talk, but a couple of things that I think are really important to recognize for AIDP is making sure that the respiratory function is good. And there is something called the 20-30-40 rule, where you can measure the forced vital capacity, you can measure their mean inspiratory fraction, you can measure their negative inspiratory flow. And a quick bedside test that you can do is asking the patient in one breath to count from 0 to 100. And if they get to 20, that's okay. If it's less than 20, it's a red flag. If it's 40, it's normal. That's an important piece to keep in mind. And then you know the respiratory techs, respiratory therapists are always key to have, so that we can actually check the negative inspiratory fraction every 4 hours at least, and keep an eye on it, because we want to make sure that these patients will not decompensate. And then a couple of other things that is important to keep in mind is that they may develop facial weakness, which may make their respiratory weakness in turn worse. They can develop some difficulty swallowing. So those are all bulbar symptoms, and by that I mean anything related to the cranial nerves is something we definitely want to keep under close scrutiny. And then so that's it for AIDP, or that's a pretty quick summary of AIDP. Now, with regard to CIDP, it's important to know that CIDP presents with sensory and motor symptoms. When we have either one or the other, then we're probably looking at something else. So if we're looking only at motor symptoms in CIDP, we may be actually looking at something called multifocal motor neuropathy, which is due to a specific autoantibody. And then by the same reasoning, if it's only sensory, we may be looking at a variant of CIDP, like a sensory variant of CIDP. Now, both for AIDP and CIDP, there is a test we can do, and it's a really, I'd say, sensitive and specific test for both of them. Does anyone know what test we would check? Sarah was saying that they had a patient with bilateral facial palsy and bilateral lower extremity weakness. Yeah, that's an interesting combo. Bilateral facial palsy has its own interesting differential, definitely GBS and myasthenia and sarcoid, Lyme, depending on where you are important. Yeah, so Sarah was saying nerve conduction studies. Yeah, so we at the institution where I'm at, we don't routinely do nerve conduction studies unless we're dealing inpatient, at least. Definitely doing it. Oh, I see. Oh, you were saying about your patient. Oh, that's interesting. Yeah, there are some variants of GBS that can present with axonal phenomena. Now, a couple of tests that we could do that I think Sarah was pointing out. One is nerve conduction studies. Nerve conduction studies, in some centers, you may be able to do them acutely. I'd say that usually the way I deal with patients with GBS is doing the LP as soon as possible, doing the LP stat, essentially. The LP will tell us both whether we have a specific finding, which is, I don't know if anyone wants to try to say what we would expect on an LP of a patient with GBS. So we'd expect the protein to be high and the white count or the CSF whites to be normal, and that's called albuminocytological dissociation. It's really a mouthful, but it's a really important finding to see in GBS, and that would give us further evidence of this. Another test you could do, you could do an MRI of the spine. It wouldn't show a spinal process, but it may show enhancement of the roots, because remember, it's a polyradicular neuropathy. And the last thing, definitely a nerve conduction study, if you can get it, urgently, emergently, that may show you whether there is axonal or demyelinating involvement. Now, a couple of caveats about all what I just said. So first of all, GBS remains a clinical diagnosis. So if you have someone with an acute presentation of neuropathy with weakness without any red flags of, something like a myelopathic involvement, with reflexes that are absent, with sensory and motor phenomena, then that's all you need. The LP may be negative. The LP may not show protein in the CSF, especially if you're really early on in the course. The MRI may not have root enhancement, and I would not do an MRI routinely on these patients unless there's another reason. And the nerve conduction study may be very helpful for sure, but it may also be false negative at the start. So if you have a syndrome that makes sense, And even with the CSF that's negative, there's not any other clear cause, then I would still say GBS is probably the most reasonable diagnosis for you. So I think that's all I wanted to say about demyelinating causes. I think one thing that I wanted to add was more so whether we have more of a diffuse uniform demyelination and demyelination that's really chronic, then you may want to think about hereditary causes. And I think it's also important here to kind of discuss this, that, you know, while CIDP has chronic in the name, and it's definitely a chronic disease, it's still a disease that pops up within 2 months or a little more. So it's something that usually comes up in the span of months. We're not talking about someone with a 10-year history of CIDP. Although some may be referred after some continued complaint from their CIDP after many years. Now I have another quick schema here on the variants of CIDP. The classic CIDP, again, it's symmetric, it's proximal and distal, it's sensory motor, again, treated like AIDP with IVIG and plasma exchange, but as I hinted at before, steroids can be given for this. And then there are some rarer variants, CISP, which is the sensory variant, MMN, multifocal acquired demyelination, can also present with just motor, so just motor, MMN, just sensory, CISP, and then a just distal CIDP would be called DADS, and then more of a multifocal sensory motor asymmetric presentation would be MADSAM. But again, these four are more for, I think, neurologists, neuromuscular specialists, definitely anyone who's studying for the boards, but I don't think it's absolutely not required at the med student level. Although CIDP is something that you may actually encounter on your rotation. And I hinted at this mononeuropathy multiplex. It's whenever we have multiple nerves being affected almost at random. And the thing that always pops to our mind is almost wanting to call this mononeuritis multiplex, because the most common causes are inflammatory. And by and large, vasculated neuropathy is a very common way in which can present. Infections, leprosy famously causes these acral paresthesias and sensory loss. It's very common in some parts of the world. I haven't seen a single case because it's really rare here in the States. Malignancies can present with a mononeuropathy multiplex. We talked about MADSAM and MMN. And then a word of caution, I guess, is about diabetes. So while diabetes most commonly presents with a distal symmetric polyneuropathy, it can present in a large variety of ways. And one is a mononeuropathy, isolated mononeuropathy. Now, these can be something like a cranial nerve 3, what we call an ischemic third, or sort of a patient that presents with an acute and painless down and out eye. And then cranial nerve 6 is another one. But otherwise, any nerve really. And the last thing that you can present with is a diabetic amyotrophy, which is an asymmetric weakness, proximal leg weakness, that's absolutely outside of the scope of today, but it's another way diabetes can present. All right, so any questions so far? Right, so I'm going to switch gears quickly and talk about mononeuropathies. This is a pretty big and involved topic, and I want to provide sort of a quick overview onto this. And I think an easy way not to get too overwhelmed is thinking about the nerves of, so I'll discuss the arm and the leg. So the nerves of the arm include the axillary nerve, the musculocutaneous nerve, the radial nerve, the ulnar nerve, and the median nerve. And really, when it comes to the axillary nerve, it's pretty straightforward. It's a nerve that the sensation is a small patch on the shoulder, and the motor function is just movement of the deltoid muscle. So pretty straightforward. Also not routinely encountered, I would say. Musculocutaneous nerve, also pretty straightforward. It's the one that controls your biceps. And then it also, the reason why it has musculocutaneous in the name is that the muscle is the biceps, and the cutaneous is that anti-cubital or forearm patch on your arm. So pretty straightforward there. And then the three that are harder to remember are the nerves of the hand, and they're the radial, the ulnar, and the median nerve. Now, the radial nerve, there is this mnemonic that they found on the Blumenfeld, great book, by the way, for anyone interested in neurology at all levels, really. This mnemonic that goes into R, U, and M. And really, the radial nerve will do thumb abduction along the plane of your hand. The ulnar nerve will do the opposite, which is thumb adduction, and the median nerve will do thumb opposition. And that's a really straightforward way to test this. Finally, and I think this is something that's commonly encountered, is knowing your sensory distribution. And the sensory distribution will be, key finding will be split at the middle of your ring finger. And the median nerve and the ulnar nerve will share a territory there. And you can see here how the distribution works here. And some quick pearls. So looking at any neuropathy, so we said mononeuropathy, we think about compression. So it's important to know where the compression will take place. For the median nerve, we really have to figure out whether it's at the carpal tunnel, which is right at the wrist. And if it's just at the carpal tunnel, it will be a sensory predominant neuropathy that splits at the ring finger, and in the middle of the ring finger, with sparing of some thinner aspect of the thumb. And knowing that the sensation splits at the ring finger instead of sparing the ring finger will really tell us whether this is a median neuropathy versus a cervical radiculopathy. If there is involvement, on the other hand, above the carpal tunnel, which is a rare presentation, then and only then will we have more motor involvement, with weakness of the joint flexors, of the proximal interphalangeal joint flexors, and the AP joint flexors. Now, an important one to remember, and this is, again, I think for med students, the carpal tunnel is the one thing to remember. There is something which is more, I think, important for neurologists here, which is knowing the AIN, the anterior interosseous nerve, which is a motor-only nerve that's part of the median nerve, and it's the one that's important to make an OK sign. So you can remember this as the mnemonic AOK. So AIN, you cannot do an OK sign. Then we go into ulnar neuropathies. And again, here, we look at whether we're at the elbow or at the wrist. At the wrist, pretty rare, and you will only have involvement of sensory loss of the two fingers, so the half of the index finger and the pinky. And this is most commonly seen, never seen a case of this either, but most commonly seen with cyclists. It's called, I think, a handlebar palsy. And then at the elbow, on the other hand, you have sensory loss of the palmar aspect of the hand, no sensory loss above the wrist. Remember, above the wrist, you have your musculocutaneous nerve. And then finally, they may have something called a Froment sign, which is they're really unable to pinch. And the reason is that they overcompensate what would be finger adduction with thumb flexion. And this is the awkward way in which folks with an ulnar neuropathy will end up pinching. Sarah is leaving us. It's been a pleasure. And then I guess since people are trickling out, I may actually stop at the mononeuropathies of the arm and we can pick up next time. The last piece I wanted to talk about is the radial neuropathy. Again, depending on the level, we're looking at the axilla, we may be looking at the spiral groove. And the way I think about this in general is with a wrist drop. So patient presents with a wrist drop. I'm sure Eseosa has come across this plenty of time, which is this a stroke? And it's tough. Oftentimes there's not a clear answer. And the reason is that the nerves that are affected by a radial neuropathy of the axilla are the same that are affected in a stroke, with some exceptions. So the extensors, such as the extensor carpulnaris, the triceps and the supinator are in common with your strokes. I will say the brachioradialis should be spared by a stroke, but it can be tough to say in the acute setting. But that's one thing we can look at, and then reflexes of the brachioradialis could also help us. With an acute neuropathy, we would expect the brachioradialis to be absent, but again, it can be a lot to just cinch hedge all your bets into these two findings. I will say the third thing you could do, and this is a sort of a recent article, a really good one though, which is you can ask the patient to make a fist. Now, usually, if you're able to make a fist, if the wrist drop corrects, then you would expect this to be a stroke. If it doesn't, it would give you further credence that this is a radial neuropathy. And actually, the drop should worsen. And the last one in the radial neuropathies to talk about is a posterior interosseous nerve, which most commonly presents with a finger drop. So your fingers are weak, although it can also present with a wrist drop. And it's usually seen with compression. I remember seeing a patient with post-surgical PIN, post-surgical posterior interosseous nerve involvement. So I think we can stop there. We can talk about the other neuropathies next time. I have still a few slides to go over, but I see that people are trickling out. So I think if you're okay, so like if you want to write, we can stop here. And Frida, in the meantime, and so if you have any questions, anything else you wanted to point out or ask about. Something in the chat. I'm glad you enjoyed the session, Frida, and absolutely, we all have a lot to learn, but it's the spirit of this is absolutely to learn from each other. So I'll stop sharing there. And yeah, well, it's been a pleasure. Thanks, Eseusa, for hosting. And I'm definitely happy to pick up another time and talk about neuropathies again. Maybe do a second session on the mononeuropathies of the leg, although maybe you could pair it with something else too. And I guess a few other topics that we could discuss is vertigo. I was thinking movement disorders could be a good one. All right, well, I'll leave it at that. It's been a pleasure. And again, thanks to Seusa for hosting. Thanks for all who contributed, and see you next time.
Thank you.